Thank you for the kind introductions. I'm glad to be able to be a part of this webinar series and share a little bit about our experience with trying to change practice in an area that for many years has not just been controversial, but very challenging to navigate. So I want to begin this presentation by giving a little backstory about neuromuscular blockade and how we eventually came to get the monitors we needed to safely use neuromuscular blocking agents. I think this is a story that we should all take heed to understand, because it tells us a lot about the introduction of new drugs into practice when we don't really have the ability to safely and adequately monitor the effects of those drugs. Neuromuscular blocking agents are by far one of the most commonly used medications in anesthesia. That they're also a drug class that many anesthetists have a great degree of a lack of understanding of their clinical pharmacology and effects. So they fundamentally changed practice of anesthesia when they were introduced. 1942, the first report of the use of neuromuscular blocking agent. It started the modern era of surgery. It made possible explosive development of cardiothoracic, neurosurgical, and transplant surgery. It improved surgical conditions, allowed for airway management and controlled ventilation in situations that we could not do that before. And ultimately, it became the cornerstone of a balanced anesthetic technique and still holds true to that today. However, these drugs entered in at a time when we just did not have the ability to adequately monitor their effects. And so as a result, we had a new drug, new class of drugs with no known therapeutic index. And I would argue that we developed a lot of bad habits and a lot of wrong ideas about neuromuscular blocking agents and how they work and how quickly patients recover and how effectively our reversal agents work. And this has been borne out with the evidence that has come since the first introduction of these drugs. 1956, Beecher and Todd had published a pretty critical report that showed a 6-fold increase in mortality after the introduction of muscle relaxants to anesthesia. And I say this because we need to take heed to understand why that was the case. Because I don't think that the average anesthesia provider believed at that time that their use of muscle relaxants was contributing to a 6-fold increase in the rate of death in the patients who were receiving them when compared to similar patients who didn't receive them. So there's something peculiar about neuromuscular blocking agents, something that enables you to think that you're doing just fine when you may not be doing just fine for your patients. And their study showed it across all patient populations that when curare or neuromuscular blockade was used, there was a 6-fold higher rate of death in frail and healthy patients versus frail and healthy patients with muscle relaxant, in major surgery with and without it, minor surgery with and without it. Everywhere across the board that a muscle relaxant was used, the rate of death was 6-fold higher. The only factor that was consistent was the presence or absence of neuromuscular blockade. And so this finding was quite controversial. And so the authors of this paper were very quick to point out that none of this adds up to proof, but all of these things are pointing in the same direction. And so they really cautioned against the use of neuromuscular blockade except when absolutely necessary. And so this really caused some upheaval in the anesthesia community. What's interesting is when the first neuromuscular blocking agents were introduced in 1942, that first report, they were using really small doses of muscle relaxant, and they were using small enough doses that the patients never required a breathing tube. They never required controlled ventilation. They were spontaneously ventilating throughout the case. And so it was likely that at the end of those procedures, there was sufficient recovery, and so we didn't see a lot of side effects right away. And then there was this explosion between 1942 and 1945 in the US. By 1946, the use of neuromuscular blockade had really begun to take hold in Europe as well. And there was another study that was published in 1946, and they introduced another technique, which eventually became known as the Liverpool technique. And they were using much larger doses of neuromuscular blocking agents, doses that were large enough to cause apnea and often require tracheal intubation. In their report, though, they only reversed 3 out of 1,000 patients. And so the take-home message was neuromuscular blockade is great. It greatly contributes to the ability to optimize surgical conditions, but there was very little use of reversal, and so reversal wasn't a routine occurrence prior to this report by Beecher and Todd showing this significant increase in anesthesia-associated mortality. And so the authors of the Liverpool technique, Cecil Gray, followed this report quickly with a response and said, don't blame the drug. It's not the drug. No, it's the technique. And so that's really where the idea of routine reversal came into the picture. And so during this 12-year period of time from the first report of the use of neuromuscular blocking agents during anesthesia until the report on how to best administer neuromuscular blocking agents through the routine use of reversal, there was some work ongoing trying to identify a device and a way that neuromuscular blockade could be measured so that not only could we determine when adequate recovery had been achieved, but also so that we could determine the necessity of reversing the neuromuscular blockade. So we see in 1958 the first report of the use of a peripheral nerve stimulator in the hospital setting, and they were essentially using it to stimulate a nerve and look to see if there was a muscular response. So it was an all or nothing phenomenon. Either there were twitches or there were no twitches. And so over this period of time, there continued to be further investigation to try to identify whether or not there's any correlation between the types of twitches, the duration of current that was used to stimulate the twitches. They were essentially doing all of the research, trying to better understand neuromuscular transmission and how best to apply this technology to the monitoring of neuromuscular blockade. So it really took another 7 years before there was even a device that was commercially available for use by the general anesthesia provider. However, even though it was available in 1965, it was far from widespread. Very few institutions had access to one of these devices, and if they did, there was only a handful of the devices in the entire institution. And so because there really was no way of assessing in every patient a baseline level of neuromuscular function, to have any sort of baseline to compare it to, it was really difficult for any clinician outside of a strict protocolized research setting to be able to understand the effects of different degrees of neuromuscular block, both on patient outcomes, but also just on some of the clinical signs and symptoms that you would witness with a patient who is partially paralyzed still. So we really didn't start moving toward an objective measure until the 70s. In 1970, so Ali and Cecil Gray, who was one of the original authors for the Liverpool technique and the use of larger doses of neuromuscular blocking agents, they wrote a paper on following a series of studies that they did on both awake and anesthetized patients. And it was really the awake volunteer studies that I think opened the door to beginning to recognize that even low levels of neuromuscular block had pretty profound effects, and those effects were variable across the population. And so they kind of laid the foundation for this idea that we really do need to be using some sort of an objective measure to determine the degree of neuromuscular blockade in patients during surgery. Shortly after their original series of studies, where they looked at awake volunteers who were receiving an infusion of neuromuscular blocking agent, and they just evaluated all these subjective signs and symptoms. They did another study where they looked at ventilatory parameters under general anesthesia, and what they found was that vital capacity was significantly reduced at train to 4 ratios less than 70%. And so this was the first time we really had any sort of a definition of residual neuromuscular block and the threshold for what we would say define as residual neuromuscular block. And that was published in 1976. So over the next 30 years, there would be a continued upward revision of the train to 4 ratio. And again, in large part to the volunteer studies. When somebody asks me, show me a study that I can read that will convince me of the need for the use of quantitative monitoring, I typically will give them one of several different volunteer studies, because there's something about being able to see the direct effects of a single drug, because everything else we do in anesthesia is polypharmacy. It's really hard to determine and discern which drug is having which effect on the patient. But when the only drug you're giving to a patient is a neuromuscular blocking agent, then all of the effects are going to be related to that. So what they do in a lot of these studies is they'll infuse an agent and they'll monitor the onset, duration, they'll monitor signs and symptoms at each level of neuromuscular blockade. And what they find across the board in these studies is that at train to 4 ratios less than 0.9, patients continue to have difficulty with their pharyngeal and upper airway muscles. And those are really the muscles that we care most about. It's difficult to swallow, it's difficult to talk, the inability to sip through a straw, the inability to protect the laryngeal opening from secretions and from fluids being aspirated. And there's even been some studies that have looked at other measures like hypoxic ventilatory response, and have shown that there's an impairment in the hypoxic ventilatory response at train to 4 ratios less than 0.9. And so this upward revision really kind of has led to a lot of other studies that looked at, well, all we have is what we can assess clinically. We don't have monitors to tell us the train to 4 ratio. And so during this period of time, there really was this kind of growing chasm between the average clinician who is monitoring neuromuscular blockade primarily through clinical tests, head lift, respiratory variables, other tests of strength, and then occasionally a qualitative monitor. They put on a peripheral nerve stimulator and confirm what they already saw with their ventilatory pattern, say, okay, see, they have 4 twitches or sustained tetany, we're good, let's extubate. So you have that on the one hand, and on the other side you have the clinicians and researchers who are monitoring patients under a neuromuscular block where they're able to quantify gradations of that block, and they directly see the effect of neuromuscular blocking agent on these patients. And so they're looking at this like, well, you can't see these things in an anesthetized patient, so how do you know when the patient is fully recovered? And so this really drove to there was a drive to try to show that none of these clinical tests were really reliable. And we did just that. There were a whole series of different studies over a period of about 20 years. They demonstrated that none of the clinical tests that were routinely used in practice were sensitive enough to identify residual block. Almost every one of those tests can be performed in train to 4 ratios as low as 0.4 to 0.5. And so it definitely caused a lot of division between the everyday clinician and the researcher on two different sides of the equation. One saying, what is the big deal? What is all the ruckus about? Why do you keep screaming for guidelines? You could see, as late as 2005, the ASA task force said that the assessment of neuromuscular function primarily includes physical examination and on occasion may include neuromuscular monitoring. It just highlights the fact that clinical tests really were the standard for the majority of clinicians. And on the other side, you have everybody who's doing the research and generating knowledge and science in this area that's saying, no, we need objective, quantifiable endpoints, because the only satisfactory method to eliminate the risk of residual block is to have a monitor that monitors neuromuscular transmission. And so we're still trying to close that gap today, because it's really hard to get somebody to begin to see that what you may have always thought was residual anesthetic effect from your inhalation agent, or residual propofol effect, or residual opioid effect, is actually residual neuromuscular blockade. It's so easy to misattribute the effects of residual block to something else. And so there's been this like circular reasoning that has occurred clinically for a long time, and for many providers, where they believe that they know more about neuromuscular blockade than they really do, and so they're not even able to correctly diagnose it when they do see it. And that's borne out in numerous different studies that have looked at anesthesiologists and anesthesia providers' perceptions of residual neuromuscular blockade, and across the board they say, yeah, it's a real problem, but just not in my practice. So it's definitely at odds with all of the studies that show rates of residual block in the PACU ranging from anywhere between 40 and 60%. So, yeah. So after nearly 20 years of screaming into the wind for guidelines and practice standards, we've finally come there. So the next part of this talk, I'm going to focus on the 8 recommendations that the ASA put forth in their practice guidelines for monitoring antagonism of neuromuscular blockade. We'll go through each of them individually before we start to talk about some of the implementation aspects. So the first 2 recommendations are focused on first defining the difference between clinical tests and assessments, qualitative assessment using a peripheral nerve stimulating device, and quantitative, what we would call monitoring. That it's not a monitor unless there's a measurement of an objective endpoint. And so we shouldn't call a peripheral nerve stimulating device a monitor, because it's not the monitor. The anesthesia provider that's evaluating the twitch response created by the device, they're the monitor, differentiating fade or no fade, or 1 twitch or 2 twitch. So they recommend against the use of clinical signs and symptoms because they're insensitive. They recommend against the use of a peripheral nerve stimulator to assess qualitatively the twitch response. And they recommend for the use of a quantitative monitor. So the next recommendation, the third recommendation, establishes just the importance of, when using a quantitative monitor, of establishing that you have a trade-off ratio of at least 0.9 before extubation. And this is, the strength of the recommendation is strong, and the evidence for this is quite good. There are numerous studies that have demonstrated that trade-off ratios less than 0.9 increase the risk for all kinds of complications, in addition to just being generally uncomfortable for patients during their post-op recovery. So the 4th and 5th recommendations look at the importance of using the adductor pollicis over the facial muscles, and this was probably one of my favorite recommendations to see come forth, because this is a huge problem that we see in practice, is people using the facial muscles to determine recovery. I think one of the key points that we really stressed when we were implementing was the fact that all of this dose finding studies for reversal agents, neostigmine when that was the primary agent, sugammadex now, are all done based on the level of recovery of the train of 4 at the adductor pollicis. And so knowing the differences between adductor pollicis and facial muscle recovery is important, because if you realize that, you know then, well, I could have 4 twitches at the eye, but yet have 0 or maybe 1 twitch at the adductor pollicis. So if I base my dose of reversal, assuming I have 4 twitches, I may very well underdose the patient. And so this was, I think, just a critical recommendation that they provided. So they not only recommended the use of the adductor pollicis, but they recommend against the use of eye muscles for neuromuscular monitoring. So the final 3 recommendations focus on, 1, understanding the depths of neuromuscular blockade and the difference between quantitative and qualitative measurement, and then looking at the appropriate level of block for various reversal strategies. So first, why is this important that we properly define our terms when it comes to full or complete neuromuscular blockade, deep, moderate, shallow, and minimal? And the way they did this was they actually divided these categories up based upon, one, signs and symptoms at each level, but also two, what you could see using a peripheral nerve stimulator in the absence of a quantitative monitor. So with complete block, that would be post-tetanic count of 0. You could identify that with both a peripheral nerve stimulator as well as with a quantitative device. A deep block begins once you have a post-tetanic count of at least 1. And again, this can be done with a qualitative or a peripheral nerve stimulating device by doing a sustained tetany and looking for single twitch responses following 50 hertz sustained tetany. With moderate block, that begins at a train of 4 ratio of, or train of 4 count, of in the range of 1 to 3. Shallow would be train of 4 count of 4. So once the 4th twitch reappears, that's considered a shallow block. And then once the fade in a train of 4 disappears, that's considered minimal level of neuromuscular block. So that would be the train of 4 ratio of 0.4 is what it equates to the absence of train of 4 fade when looking with a peripheral nerve stimulator. And so then what they said in terms of reversal, that regardless of the drug used, if you're in terms of cisatracurium versus, so your immunosteroid versus your benzoyl isoquinolones, if you're going to reverse with neostigmine, then you need to withhold reversing until the patient has spontaneously recovered to a minimum train of 4 ratio of 0.4, or to what is defined as minimal block. Because in all the studies that were done, the only time that you could achieve full recovery in all patients after the administration of neostigmine to either of those drug classes was at the train of 4 ratio when it would exceeded 40%, and where fade was no longer detectable, and if you waited 10 minutes. So that is, if you're not quantitatively monitoring, the only way that you can guarantee full recovery in your patients is by waiting for a train of 4 fade to disappear and then waiting 10 minutes after the administration of neostigmine. So one of the things that also could be considered from this perspective is, if you're thinking about cost savings, if you have a patient with minimal levels of neuromuscular block, consider using neostigmine over Sugammadex. And then in terms of the use of Sugammadex, essentially anytime you're using rocuronium or becuronium, they recommend using Sugammadex anytime the train of 4 ratio is less than 0.4, so fade is present, or below that, so any of the other levels of block. So I think that this is the point where a lot of people might say, well, if I'm using Sugammadex, then why do I really even need to monitor? Doesn't that eliminate the need for quantitative monitoring? I think if we think about this, so all of the dose finding studies for Sugammadex are done using quantitative monitoring, looking at an objective endpoint for determining the optimal dose. They're using quantitative monitoring at the adductor. And so if you're basing your dose of reversal off of clinical signs, you have no idea what level of recovery you actually have. And even if you're using a peripheral nerve stimulator, you still would need to dose your reversal based upon, the number of twitches you have, but you still don't have any guarantee that that the patient's not going to have any residual neuromuscular block. And this, there is variability in the studies that have been done. When you pull together all of the studies that looked at Sugammadex blindly administered without quantitative monitoring, there was still a 10 to 30% incidence of residual block across all of the studies. And so it is possible to give Sugammadex and not have full recovery. And we've seen this in our own institution. I'll show you some examples in a few minutes. So we have those recommendations. What do we do from here? And I put this slide in really because, so in 2018, the Anesthesia Patient Safety Foundation had a task force that essentially was trying to call on the ASA to put out guidelines for neuromuscular blockade and management, reversal, and the use of quantitative monitors. And so this is kind of the preamble to what we finally have now. And so as part of this consensus statement that was put together by this expert panel, they have a whole table of education and training that should be considered. And a huge part of the education that they provide is what we've already talked about in this, that, to begin by defining the incidence of residual block, to help your colleagues understand the difference between quantitative and qualitative monitoring and what are the limitations associated with each of those, understanding the limitations of clinical tests. All of these things are critically important, but I'll tell you, based upon our own experience, that I could tell somebody all day long these things. And it wasn't until I went into a room where they have a patient who they've extubated, who they're struggling to, maintain airway patency, or the patient's, they're at risk for being reintubated, and I put the monitor on, and sure enough, Tranafore is, I've seen as little as 1 and 2 twitches, and as high as ratios of 70-80%, still having patients that were suffering from the effects of residual block, so much so that it was affecting their airway and causing an emergency situation. And then, because Sugamidex has been very beneficial from this perspective, it allows for an immediate recovery of symptoms. So you administer a small dose of Sugamidex, Tranafore ratio jumps up to 95-100%, and there's complete resolution of symptoms. And so that's really what it took in a lot of scenarios with those people who were just slow adopters. They had to see it to believe it. And fortunately, the difference between now and when we implemented it, and even 2018 when these consensus guidelines had come out, the difference is that we have a major authoritative body saying that quantitative monitoring should be the standard of care. And so that will push people to be more likely to implement, because I will say, even in our institution, after these guidelines came out, we had a whole nother educational series about, okay, now it's really time. If you still weren't using it, now's the time to do it. And so I would really focus more on the training component than anything else, with education being in the background to training. And so they outline, several points here about training, which I agree with all of these, because this is essentially what we did. And they talked about having key people who you identify in your institution who are going to be early adopters and who want to become the experts in this device. And before you roll it out to the whole team, start off by allowing those individuals that you've identified to build up their experience. And I think this report, they recommend a minimum of 50 cases managed, a minimum of 50 patients managed with the use of the monitor. And the reason I say that is because the worst thing that you can do is to have this widespread implementation across the board and have no experts, have nobody there that is trained to troubleshoot and help. And so I would definitely refer to these resources, to this resource, to help you kind of think about a plan of execution when implementing. And then the last thing they provide in here is just some equipment recommendations, and choosing between what kind of monitor you use. There are new monitors coming out, it seems like, biannually now. We have 2 different monitors that we use in our institution, one of which is pediatric approved, and the other which can be used on all patients, but our peds team always likes to be different, so they have their own monitor. So now we'll move on to some of the barriers that you might experience when it comes to implementation, and I'll try to give some recommendations. Kicker for many people, but when talking about the quantitative monitors, they're all different. We use EMG. Both of the devices we use are EMG technology. We also have the KMG, the kinemography, which we've really largely gotten away from because the EMG seems to have more reliable measurements in situations where the arms are tucked or there's limited movement of the thumb, for instance. And so it's really important that your colleagues understand what you're like which nerve you're stimulating, and then the muscle that you're monitoring, where it's located. This is something for us that was kind of surprising. You tell everybody ulnar nerve stimulation, you monitor the actopolysis, and to see where people would put electrodes would blow your mind. And so that was one big component. The second component of it is helping them to understand the actual signal that is being displayed for them, because that will help with troubleshooting. And so really focusing on what the display looks like and setting it up in your own institution. If this is going to be a monitored signal that you have incorporated into your monitors already, your anesthesia monitors, versus if it's going to be a freestanding device to the side. But if you do have it incorporated into your anesthesia monitor, just thinking ahead about how you want that to be displayed, so that the clinician, whoever's using it, can always see the actual physiologic signal and not just like a number that's up on the screen. In the same way that you would never want, an EKG, without the waveform. You want to see the waveform and the numerical, heart rate. You would never want to just see your heart rate on the screen. I would argue the same is true with the quantitative monitors. And then the last thing is just, quantitative monitoring, it uncovers so many gaps in knowledge related to basic neuromuscular physiology and function, from duration and onset and different drug interactions. And so I'm going to go through each of these individually just to kind of point out some of the. So one of the things that can be easily taken for granted about quantitative neuromuscular monitoring is that this is really the first monitor that we use in anesthesia that not only monitors some physiologic signal, but it actually creates the signal that it then monitors. So it's critically important to place electrodes in the right location, or to place the sensor in the right location to make sure that you're over the nerve and over the muscle. And I think that some of our sloppiness that we have with monitor placement with some of the other monitors, this is just far less forgiving. You can put EKG leads pretty much anywhere and still have some sort of a monitored waveform that you can look at. But you cannot place stimulating electrodes over the median nerve and expect to see, a response in the adductor pollicis, or vice versa. Place your electrodes over the ulnar nerve and then put your recording electrodes nowhere close to the adductor pollicis. You're just not going to get a good signal. And so we just need to make sure that we start with the basics and make good pictures that highlight where some of these things are. In terms of understanding the physiologic signal, so for us, it was surprising to see that most people don't really know what a compound muscle action potential is, that what a muscle, what it looks like in a depolarization waveform. And so helping people to know what they should be seeing on the screen. If you see some, non-physiologic wonky line, it's something's not working. Either you don't have good electrode contact, start all over. Don't just say the monitor is no good, it's not doing anything. And so we found it critical to display the signal. And then beside the signal, you could have the numerical display as well. And then the other thing that I also found to be extremely helpful is to show the trends. So you could see the train-of-4 ratio, decreasing and increasing over time. So you could see the first twitch height, increasing and decreasing over time, because that just gave you a reliable, there's no way to have a false physiologic signal that increases at a percentage of 1% per minute, or whatever the patient's recovery response curve looks like. And so being able to have that trend display was also really key for us. So just being smart and thinking ahead about how you want this to be displayed. And again, that's going to be different, I think, for different institutions, but having those expert users up front who get to use this monitor and really familiarize themselves with the monitor will be key to figuring out what is going to work best for your institution. And then in terms of some of the knowledge gaps on basic neuromuscular, like just pharmacology. So I don't know, I think I alluded to this earlier, but even in school, I remember questioning the people who were training me when they said that clinical duration for rocuronium was in the range of 35 minutes. That's what I had always remembered. You give an intubating dose of rock and you can expect within 35 minutes to have recovery. And I knew for certain that when I read in the textbook was that that was not full recovery. And it's not. It's recovery to a twitch height of 25% or a train to 4 ratio of the first reappearance of your fourth twitch. So that's not recovery. That's just recovery, fourth twitch recovery. And so helping people to understand that, because when you have a monitor that is showing in the majority of your patients that 35 minutes after an intubating dose of rock, they're not fully recovered, people begin to question the reliability of the monitor rather than question the reliability of what they think they know. And so this was, I think, important for us to kind of show some of the nuances of pharmacology that they may have simply misunderstood. And the same goes for how quickly the drugs take effect. I've seen this often where, you know, the quantitative monitor is telling you still have 4 twitches, you know, what feels like to them forever, but, you know, 90 seconds after the intubating dose of rock was administered. And so, you know, they'd be like, oh, the monitor can't be right. And it's like, you're looking at the hand moving, you're looking at the waveforms on the screen, and they're telling you the monitor's not working because they know better that the drug should be working already. And so helping people to understand how quickly the drugs work. And then I think another component of that is understanding the difference between laryngeal muscles and the diaphragm and the adductor pollicis. And so what we frequently see is that, yes, the laryngeal adductors are fully paralyzed well before the adductor pollicis is reading, you know, less than 4 twitches. And so just helping people to correlate what the monitor is telling them with what is true in basic pharmacology literature on these drugs. And then in terms of recovery, this is, again, another big pitfall we find is I get called into a room. The monitor's not working. It said I had no twitches and the patient's coughing and bucking, to which I say, well, that's very possible for the patient to be coughing when there's no twitches that adductor pollicis because of the recovery rate of the diaphragm. It recovers so much more quickly, which is also the reason why I say you can't rely on, you know, tidal volume ventilation at the end of the case to tell you your patient's fully recovered, because you might still have no twitches at adductor pollicis when your patient's, you know, fully recovered from a ventilatory assessment. And so helping people, again, just to know what the original studies demonstrated with neuromuscular blocking agents and the recovery at different places. This next, so this is one of my favorite videos to show unbelievers about the benefit of monitoring and the unreliability of what our eyes sometimes see when it comes to ventilatory parameters. This is a patient with 0 twitches at the adductor pollicis. And you'll see definitive movements in the abdominal muscles right here and the diaphragm. The patient has diaphragmatic effort, is attempting to breathe. Obviously, the upper airway is completely obstructed and is requiring our continuous positive airway pressure to maintain the patency of the airway, but there's no twitches. And so this is a case in point for why you can have a patient with normal tidal volume ventilation at the end of the case that is still fully paralyzed. Okay, so the last area that we found there was a lot of education that was needed was just, again, all of this, if you read through the studies, every different area of study when it comes to neuromuscular blockade, whether it's the pharmacology of the agents themselves or the dose finding studies for reversal or the residual block studies or the correlative studies that are looking at the correlation between different tests and quantitative measurement. All of this is in the study. So it's kind of cool when you have a monitor that essentially is like textbook defining what you know to be true in theory, and you can actually see it in practice. And so interpatient variability is something that is across the board discussed in nearly every study. And this just, shows here a single intubating dose of rock, 40 milligrams, which is a little more than 2 times the ED95. But it took this patient from 8:25, so over 2 hours, just 2.5 hours, just to get back to what the textbook would define as the duration of effect, to a train to 4 ratio of 0.2. So this is like the first reappearance of the fourth twitch. And then right here, look at this drug interaction. Magnesium is administered, 2 grams of magnesium right here, and you see the drop in the train to 4 ratio, followed by 55-minute time period before the train to 4 ratio would recover to the previous level before the magnesium was given. And so being able to see this borne out in practice was just really, I would say, eye-opening, because what if the end of the case had come and you decide to give somebody 2 grams of magnesium after they, spontaneously recovered to a train to 4 ratio of 90%? You've got an hour of a patient who could very well be brought down to train to 4 ratios low enough to cause significant airway compromise or other, significant weaknesses. So being able to demonstrate this by measuring quantitatively the effect of a single drug you're given. Here's another example of magnesium given. You see if the patient has full recovery to 90%, and then 2 grams of mag are given. It takes 85 minutes for that patient to get back to the full recovery after magnesium. So I'm going to end here just talking about some of the things that really helped us to get buy-in, because yes, changing practice is so hard. For us, I think one of the biggest keys was just that team approach, having a physician anesthesiologist and a CRNA, or whatever it looks like in your institution, having people on both sides who are advocates for this monitor, who believe in it, and who are super users, who are expert users. And then I think, just continuous education and reminders. We would send out emails and say, hey, look what we found today, or here's another example of, how the monitor saved the day. And then I think the third component is you have to continue with re-education and with training. And so we had, and with specific people, so you find your key players, and that is who onboards all new staff, whether it's residents during their annual residency training, and their initial residency training new to the OR, or whether it's, the CRNA, whatever that looks like. You should have a consistency in what you're teaching people when they first come into your institution, and then annually thereafter, which is what we've consistently been doing, and it's worked quite well for us. So just some little tidbits to put the cherry on top. These were all things that we found in our own practice. This was a patient who had previously been reported that she was slow to wake up, who actually ended up having an unexpected reintubation and admission to the ICU after she had had cervical spine surgery. She was supposed to go home that day. It was a posterior laminectomy. And when I looked back at the record, I saw, okay, she had 50 milligrams of rock on induction, and then she got neostigmine reversal. It was around 60 minutes later. And so I was like, I wonder if this patient was a slow recoverer. And so I took care of this patient for a completely different surgery. This is a laparoscopic procedure, and we gave her a ED95, 2 times ED95 for intubating dose, 40 milligrams of rock up front, and then watched. And 160 minutes later, she still had no twitches. So her first twitch did not recover for over 160 minutes, which tells me that that prior procedure where she had 50 of rock and was reversed in less than half that time, there's no way that she was fully recovered. So it's almost guaranteed that her reintubation and ICU admission was completely related to her variability in the response of to rocuronium. So you can see here's the first recovery of the first twitch, and then we give Sugammadex after she had 2 twitches back. So this is a 2 twitch recovery. We gave her the appropriate dose, 2 milligrams per kilogram, and it took 30 minutes for her, after giving her her full dose of Sugammadex for her to have recovery to a train 4 ratio of 94%. And what was interesting about this case was even at 94%, she still had some upper airway and pharyngeal collapse that when we gave an additional dose of Sugammadex after that, spontaneously recovered. And so this is after extubation, just showing that, we extubated her and, her SATs decreased. She had a subjective feeling of, like she felt like it was hard for her to take a deep breath, and just like that, a feeling of kind of like it was hard to breathe, but not in any clear respiratory distress. So I point this out because this is a case in point of, you see this and it will forever change your practice, because you don't want to be the one who reintubated this woman because you didn't monitor her. I think another thing that this monitor really allows you to do is to be precise with what you're doing. We talk about precision medicine all the time. Like, how about avoiding unnecessary drugs, not giving things when we don't need to give them, or giving the right doses? This is a case where, we were able to give rocuronium. The patient had a very fast recovery response curve. You can see very quick to recover. And then we finally decided, let's just start a drip. So we started a drip. You can titrate it with precision to a train of 4 ratio of, 20 or 30% or whatever you want to titrate it to. And here's your train of 4 ratio just trending at its nice constant, because of the constant rate of the infusion, and then turning it off right here, and then spontaneous recovery, avoiding reversal unnecessarily for this patient. So something else that really helped us to get more people on board and to have more buy-in was when we would find the unexpected. So this was actually a case series that we did after we had just done a QI project on the incidence of residual neuromuscular blockade in PACU, and we found this disproportionate number of patients who were having neurosurgical procedures with neuromonitoring that were showing up to PACU with train of 4 ratios of less than 0.9. And this is kind of confusing, because the whole reason that we didn't expect this was that we were monitoring motor and sensory evoked potentials during the case, and the neurophysiologic monitoring team is telling us that the patients are fully recovered. They have 4 twitches. And so we started putting on quantitative monitors during these cases. And what we found was pretty fascinating. We found that once SEP stimulation was initiated, and so with SEPs, you're stimulating the ulnar nerve or some peripheral nerve and looking at the response in the sensory cortex. And so when they would stimulate, they would routinely do the ulnar nerve on the upper extremities, and they stimulate it less than every second for about 3 to 5 minutes. So it's like constant stimulation. And what was happening was that it was creating like a potentiation effect. So we did this case series, 14 patients, and we found every single patient after the initiation of SEPs had a sudden acute increase in the measured train of 4 ratio on our quantitative monitor. And then as soon as the SEPs were cycled off for that 3 to 4 minute period of time, the train of 4 ratio would slowly regress back to its true level. And we found a few interesting things. One, we noticed that the train of 4 fade would disappear, right? So this is before SEPs are being stimulated or being run. And then 2 minutes after SEPs are started up, this is what your train of 4 waveform will now look like. You'll see on the monitor displayed 4 equal twitches with a low T1, but 100% ratio. And you can see here to the left of the waveforms, this trend screen. So you can see where the train of 4 ratio is initially, it's the white bars, it's initially increasing, and all of a sudden the first time monitoring is started, you get this acute rise for the 3 or 4 minutes that it's cycling on, and then it cycles back off again, and you see return. So you can see the true recovery response curve in the background behind all of the interference during the SEP monitoring. And so there was, of the 14 cases, we had 3 out of just that 14 case series where we had patients that had incomplete recovery at the end of a case. And the duration of effect ranged anywhere from 270 to 330 minutes after the last dose of paralytic, that patients were still with train to 4 ratios less than 90%. This is just an image of the flow sheet where you could see along the bottom of the flow sheet. So that orange represents train to 4 ratios. You see the initial intubating dose of 8 of rocuronium, you see a drop in the train to 4 ratio, and then you start to see the train to 4 ratio increasing. Where that second arrow is, labeled B, that's where SEPs are started. You see there's an immediate increase in the train to 4 ratio to 100%. And then there's a redosing of rocuronium for surgical exposure, so you see it drop back down again. And then SEPs are typically off during that time because of all of the EMG artifact from bovying. And then once SEPs go back on again, this is the arrow labeled D, you see again a sudden and acute rise in the train to 4 ratio. And so each of those green bars, that's SEPs off. So you could see the true train to 4 recovery response curve on that bottom orange line, and then the false recovery curve up ahead. And this is one of those patients that at the end of the procedure, you see point F, patient still had a train to 4 ratio 80%. So we gave a very small dose of Sugammadex, I think 25 milligrams, and then you see spontaneous recovery. And again, notice that there's no variation with SEPs on and off at this point, because what the SEPs were doing was just creating a post-tetanic facilitation of sorts, related to the calcium and acetylcholine changes that happen with that rapid rate of nerve stimulation. And this is just showing you over the course of time for a single patient. So you see time frames, you see at 10:51, SEPs are actively on. So it looks like you have a 4 equal twitches, train to 4 ratio of 97%. Once they go off, after the first minute, the train to 4 ratio reduces to 58%. A minute later, with it still off, you see 52%. And a minute later, you see the train to 4 ratio is down to 47%. And so this just shows you that some patients, there's a normalization period of up to 3 minutes. So this actually led to us revising some of our neuromonitoring protocols that required that train to 4, if we're going to rely on them for monitoring train to 4, that the SEPs have to be off for a minimum of 60 seconds or until the train to 4 ratio stops decreasing once SEPs go off. So anyway, I say all this and tell you these stories to say that it's often not until you start using quantitative monitors that you begin to see an increase in interest and an increase in buy-in, and that will only happen if you have local champions and experts in your institution that are using this monitor, that are highlighting these things and sending out communication saying, hey, look what we found, hey, look what we didn't know that we didn't know. So I hope all this will spur you on, and I'm going to end the presentation at this point, and we will open up for questions.
Thank you, Erica, for taking the time to share your expertise and your clinical insights. We will now address questions that were submitted during the presentation. If you are still having questions, you can enter them into the Q&A chat. At this time, we are only able to answer questions that were submitted in English. Additionally, please note that the questions and responses may not be relevant in all countries. So the first question in our queue is, first of all, they would like to thank you, Erica, for your great insights. And then the question is, there is a false perception that when reversing patients with Sugammadex, there is no need to use quantitative NMT monitoring. Could you please comment on how NMT monitoring can help dose and time reversal agents and ensure full recovery from neuromuscular blocks?
Yes, so I think there's several different ways that you can look at this. One is using the trends that you've had over the duration of the case. You can identify early on whether or not this patient is a slow recoverer or a normal or fast recoverer. And so if you have somebody who, I think I showed an example of, one of the patients that took 220 minutes to recover to the first twitch. If that's the patient, then when I get to the point of reversing that patient, I would think differently about reversing them. And I wouldn't have that information without the quantitative monitor. And so I may give a higher dose or reverse them much earlier to ensure, because if they're that slow to recover throughout the case, they're likely going to be that slow to recover. They're going to be outside the bell curve in the extremes of recovery once you give reversal. So I think that you can, the benefit of quantitative monitoring is that you have the entire case to get to learn that patient and identify where they fall in terms of variability. So that at the end of the case, you can do a better job of reversing them more precisely and ensuring that you give enough time and you're not delaying the end of the case and turnover in the OR because of how long it takes the patient to recover.
Right. Our second question is, how accurate can muscle and nerves of the lower extremities, legs, be in measurement of neuromuscular blockade?
That's a good question. I've never used the legs with the devices that we have. However, I've learned a lot about the difference between upper and lower extremity recovery rates through our neurophysiologic monitoring that we do with a lot of our neurosurgical procedures. One of the interesting things that we saw very early on was that after I would have full recovery, so let's say this is a case where we've paralyzed the patient up front and then we want to reverse them so that we can start monitoring, and you administer the reversal agent, I'll have full recovery at the adductor pollicis, and they'll find that at the legs, and they will too in the upper extremities, but the legs, there's somewhere between an 8 and 10 minute delay. So it's interesting to see that there is a difference between the uppers and the lower extremity. I think it also, some of it depends on the patients as well, but before they were able to get a train to 4 ratio in the lower extremities with some of our spine surgeries, they would see a significant delay between the two. So I think if you use the lower extremities, if you have a device that is able to be applied to the lower extremity, that might even be a step ahead or a step above using the upper extremity because of the delayed recovery. You could really ensure that you would have recovery of the upper airway muscles and the pharyngeal muscles.
Great. So our next question is, the clinical benefit seems clear, but we all know that the adoption of new technology generally comes with a cost. Could you speak to the ROI and approach you took with your C-suite to gain buy-in for widespread adoption of NMT?
So I may not be the best person to answer this question. First, because when I came to the institution that I've been at my entire career, every one of our ORs had these monitors already because we had previously been a part of a study that we used these monitors for, but nobody used them. They just sat on shelves collecting dust and in our anesthesia workroom. And so we already had the devices. Now, I will say one of the ways that I used to get buy-in with a lot of people to try to get the upper leadership to be in support of this, to try to push it from a top-down perspective, was I would routinely submit. We have a safety reporting system that, when you submit anything that goes to all the hospital leadership. So when you submit a patient event where there's a patient who was reintubated and there's a high likelihood that that patient was reintubated because of residual neuromuscular block, because I did a lot of case review, and I would do this for educational purposes. And so I would submit an SRS on any case that I thought was potentially related to a residual neuromuscular block, as well as on cases where we kind of saved the day because we were using monitoring. And that got the attention of a lot of upper leadership. I think it only took 2 or 3 situations before the head of our pharmacy department was saying, why are we, not using Sugammadex on all of these patients? And then also really started to push for quantitative monitoring, not just in our ORs, but there was also a push for considering ICU protocols when we're transporting patients to the ICU. Should we be reversing these patients since there's no way to quantitatively monitor them at the moment in the ICU setting? So it generated a lot of discussion. So I think those are 2 ways you can consider it. But again, I didn't go through the process of convincing anybody at our institution because we had all the monitors already.
Okay. So our next question comes and it says, if the train of 4 response is telling you that it's above 90, but the first amplitude you see is very shallow, as is the 4th, can you still trust the ratio shown?
So I would, in this situation, I've seen this happen before, and most often it's because of an increase in impedance over time. So if it's been a longer case, and so you're seeing the response that you're seeing is decreased all around. I've also seen this happen as a result of,
something I can't identify. And so the first step I would take, depending on the device you have, is to increase the current that you're delivering to see if you can achieve a higher T1 after increasing the current. One thing I can say is that I've noticed with when we did this project with our neurophysiologic monitoring team, they said that it was not uncommon for them to have to increase current over time during the case with their SSEPs, and in order to evoke greater responses, that there would be a natural decrease over time. And some of it had to do with a decreasing anesthetic depth from a propofol infusion, for instance, not being properly titrated over the course of the case. And so I think it's a hard question to answer because there could be different reasons why that could be, but I would try to rule out that there's not a generalized weakness for some reason, and also try to rule out that the electrode contact is not, you don't have an increasing impedance over time that is just requiring you to increase your current delivery from the baseline current that was set.
Okay. So the next question in the queue says, hi, Erica, thanks for the really great presentation. Do your anesthesia people get frequent feedback on how your patients are doing in PACU and later in the ward? And if so, how do you see NMT monitoring has affected the post-op outcomes?
Well, when we implemented our go live implementation was in 2016. And so between 2013 and 2016, that was just a huge learning period for me, and I had a physician colleague who I had teamed up with, and the two of us, basically we used it on every patient for 3 years. And I did a whole series of lectures trying to get people on board, but we didn't have official buy-in from our upper leadership within our department until 2016. And that's when we did, all of the residency training, and we ran rounds and started our real educational initiatives from a departmental level. And so after 2016, we did do a PACU study where it was a QI project where we measured train of 4 ratios on all patients upon return to the PACU. And we found within the first week of doing this, and this is also around the same time that sugammadex came out, but we didn't yet have it in all of our ORs stocked. It was something you had to request from pharmacy. So you had to do something extra to get it. And so in the first week, we identified like certain populations of patients that were almost consistently with train of 4 ratios as low as 40% in PACU. And so we saw within the first week a huge uptick in the adoption of this monitor when people saw that, oh, wow, my patient's getting monitored upon arrival to PACU. And then we also saw a big increase in sugammadex use. Our thoracic surgery was not using sugammadex at the time. They basically changed their protocol in that first week that all patients with thoracic surgery were going to get sugammadex. And so there was that component. But then we had, leading up to this, had really done a lot of investigation in terms of how many reintubations do we have per year. And we averaged 1 to 2 reintubations per month. And ever since I would say it was 2018 is where we started, because 2016 to 2018, it took about 2 years for us to really go through, full residency groups, where by the time the first year residents were second and third year residents, we really had consistency in the use of this monitor across all teams. And so by the time we got to that 2-year point, we saw our reintubations significantly decrease. I think we average like 3 to 4 per year now, instead of somewhere in the ballpark of 12 to 24 over the course of a year.
Wow, those are some pretty good outcomes. Our next question is, can you use NMT if you do not get a baseline measurement?
Yes, you can. And so this is a good question, because I think one depends on the device that you're using. I'm only familiar with a handful of devices, but the whole piece about train of 4 is that the train of 4 ratio does not require a baseline. Now, depending on the device you use, you won't have a reference waveform, so you won't have like a first twitch or T1% comparison if you don't get a baseline. But you can put this monitor on any patient and just pick a current, essentially, if this is a device that requires a baseline to set the current, you can just choose a current and deliver that current in the same way you would put a peripheral nerve stimulator on, choose a current, and then look at the response. You can do the same thing with this device and just look for the measured train of 4 ratio. We've done this, and we had a couple succinylcholine patients with butyrylcholinesterase deficiency that did not wake up from anesthesia. And sure enough, we put the monitor on, had not had it on from the beginning, and were able to put it on and successfully monitor that patient and recognize what was going on. So yes, you can do it without a baseline.
Okay. So that's what we had as far as questions currently in the chat. I'll wait just a few minutes here and see if there are any more questions that come in. But I do want to let people know that this session has actually been recorded. And if you want to access the recording, it will be on our clinical view site. And the address for that is clinicalview.gehealthcare.com. So again, it's clinicalview.gehealthcare.com if you want to access that recording. So I do not see any additional questions. So Erica, before we end, we would like to also ask for everybody's feedback by answering a 5-question survey, which will appear at the close of this broadcast. It's going to take you probably no longer than 2 to 3 minutes to complete, but that information really helps us as we're setting up future programs. Thank you once again for your time and attention, and we look forward to seeing you again soon. Thank you, Erica.
Yes.